Dr. Ramu Karel, and I am an assistant professor of emergency medicine at Brown University and founder of FAPSA Nepal, as well as the Poision Center in Nepal. So it's really good to have everyone here. Today we have a very, very honorous lecture. Honor to have Dr. Ziad Kazzi, as many of you probably have heard from him before. But before we introduce him today, I would just like to share a few updates from our Poison Center, from HAPSA, from Dhulikhel Hospital, and so on. So, as you all might know, HAPSA is working to sort of bridge the gap of emergency care across rural regions in Nepal, and this includes communities, this includes hospitals, as well as healthcare providers. So, if you are interested in things like that, please always connect with us. You can email us, you can go to our website, and all that. Um, a special announcement for today is really a save a date for you. So I want everyone to really keep this date in mind, December 15th and 16th. Learning. We'll have a pre-conference workshop that will be certified. We'll have international faculty joining us, including Dr. Ziad Kazzi, who has already confirmed to come from all the way from Atlanta. So, and the best way to again stay connected with this is to follow us on our Instagram page. But this is going to be an awesome opportunity for everyone, and I hope that everyone can join. So please save your date, and as things get finalized, we will happily share more information with you. I also want to remind you that we've been doing pretty much monthly lectures and high yield topics, kind of lectures with really amazing speakers from around the world since we started the Poison Center about 2.5 years ago. And all of this is available on our YouTube page. So if you use this QR code to go to the YouTube link, you can watch all of these lectures at your own leisure as well. And if you are interested in anything, right, from lead poisoning to organophosphates to snake bite to anything, and you are interested in research, you want opportunities, you want to connect with us, you want to learn about Poison Center, you want to, join Emory's and Dr. Ziad Kazzi's lectures that they do around the world. You want to come to our conference. Ziad Kazzi runs MENA Talks, and this year it's going to be in Morocco in, I believe, March.
Correct.
So, if you want to be part of any of these opportunities, you can always reach out to us, and then we can connect you to the right people. So these are wonderful opportunities you have with our international faculty. So with that being said, I would like to briefly introduce who really doesn't need much introduction with this group, but Dr. Ziad Kazzi is a professor of emergency medicine and clinical toxicology at Emory University in Atlanta. He is the director of the International Medical Toxicology Fellowship Program. He is also assistant medical director for the Georgia Poison Center. He is currently the president of ACMT, the American College of Medical Toxicology. He is a past president, founder of MENATOX, the Middle East and North African toxicology group. Really has a footprint in toxicology around the world, and does a lot of work in toxicology, and particularly loves Nepal, and has been a big supporter and a guide to us for establishing Nepal's Poison Center. He has agreed to give us a lecture today on clinical approach to management of corrosive ingestions. And I think this is a lecture we have not had before. So we're really excited to welcome Dr. Ziad Kazzi. So Dr. Kazzi, the floor is yours, and please, you can share your screen. Let me stop my share.
Thank you, Dr. Karel. Hello, everyone. Namaste. It's a pleasure to be with you. I look forward to actually being in Nepal in person. I've heard so much about Nepal from many of you, including Dr. Karel, whose passion for Nepal really inspired me. I shared similar passion with Dr. Karel for the country of Lebanon, where I come from, as well as the country of Georgia, where my wife is from, and the region of the Eastern Mediterranean, where I worked primarily for the past almost 20 years. It's um, really important to recognize the work that you are doing. You are basically uh, building a Poision Center from the ground up using your grassroots movement. I think this is commendable, and it is a privilege for many of us that are participating in your international expert WhatsApp group to support you on these difficult, challenging cases that you have to deal with. So, again, we are honored to be part of your group, and we congratulate you on your effort. I wish you the best. I think the Poison Center is a hidden gem. As Dr. Al Bronstein, the past president of the American Association of Poison Control Centers, or America's Poison Centers, said to me once. He said the Poison Center is the best kept secret. So, congratulations. Keep working. Don't give up. It takes time to reach the momentum and the sustainability that you need. But I think you're on the right track. You are clinical. You are providing public health interventions. You are preventing poisonings, hopefully with education and recognizing hazards. And publishing your reports is also essential to really grab the attention of the stakeholders, like the government and other international partners, to support your effort. And we do that at Emory as well through our training. We have a Center for Advanced Emergency Care Clinical Toxicology Certificate Program. And a few of my current certificate program members are here today from Turkey and from Cyprus, actually. They're on the call today. So that's why I'm recording this, because a few others were not able to join. So I would like to share the recording with them. So, Dr. Carell asked me to talk about corrosive ingestions or caustic ingestions and talk about this from a clinical perspective. And we have about 40 slides. Some slides are amenable for more discussion. And certainly, I look forward to hearing from you as well. For an important reason is that the management and assessment of these patients is really also context dependent. And me sitting here in Atlanta, I understand completely, since I also practice in Lebanon and Georgia, that it is completely context dependent and varies by country, by community. So, I'm gonna throw at you a couple of presentations that I've seen. These are my cases. This woman here was a suicidal patient. She came to Grady. She ingested household bleach. We can talk about what that is. Household bleach. Bleach, is a bleaching agent. It makes things, it turns paper white. That's why it's called bleaching. But the other reasons why it's used is as a disinfectant. We saw a lot of bleach used during COVID and the increased number of use of bleach. But the chemical name for bleach is sodium hypochlorite. Now, this woman was suicidal. She drank household bleach, which is not very concentrated, and she drank a glass, but she was symptomatic. She had symptoms: vomiting, hematemesis, abdominal pain, and some mild sore throat, which is not surprising. Her airway was okay, but she was symptomatic. Her vital signs were okay, but she was tender on her abdominal exam, and her mouth had some erythema. So, we were concerned a little bit because of her exam, although she ingested household bleach, but she was suicidal. When you add the suicidal factor to your history, that means the amount that they report to you is not accurate potentially. People do this in an impulsive manner. They're not really watching how much they're drinking. They're trying to harm themselves. It is possible that they drank more than a glassful. And when you increase the volume of something, even if the concentration is low, you increase the dose. And poisoning severity is directly related to the dose, not the amount. So remember that. Concentration, if low, is safe, but if you take a lot of it, then you lose that protective effect of a low concentration product. The rest of her labs were normal, and she was actually uh, scoped by our gastroenterology service. And I'll show you here a few things. Just pay attention to this a little bit. We're not gastroenterologists, so we could just read this, as a medical toxicologist. But if you want to look at this a little bit, you see that there's numbers, one, two. This is where the actual on the esophagus, where the pictures are, and you'll see some superficial erosions. These are gonna your least significant findings. You know, We'll talk about the grading later, but this is like your lowest grade. And they call like exudates, like this whitish stuff. This is what it is, and some erythema. Okay, these are all findings on the endoscopy. But look here. Now you see, particularly in 14, for example, you see this necrotic. Now you see black things. You see in 6 and 5, blackened areas. These are necrotics. Okay, those are bad. Okay, so when you look at these findings, appreciate the color. Is it just erythema, like the lower slide here? Sorry, the slide here, 15 or 14, which is necrotic. Also appreciate if it's circumferential or not. Circumferential always increases the grade from A to B. If it's just a discrete area, that's an A. If it's circumferential, it's a B. And we'll talk about the grading in a second. But this is what they read it. Circumferential caustic burns from the mid esophagus to the gastroesophageal junction. Circumferential erythema was disclamation seen. Okay, this is grade 1. Why is it grade 1? Is because it is erythema. Okay. And then you look at the stomach, you see grade 3B. This is the highest level because here you have circumferential. Remember, I told you circumferential is a B. And it's also hemorrhagic, deep gray, brownish ulcers. These are basically necrotic. Okay, that's your 3. And we'll talk about this a little bit later, but this is a classic example of a case that surprised us because this was bleach, household bleach, which we often, don't raise a lot of alarms on, but suicidal and symptomatic. So again, a great example of how low concentration, large amount, suicidal intention can cause different outcomes. Um, her outcome was good. So I won't. But she was in the hospital. You know, several days, 17 days here listed on this slide. Discharged to psychiatry on day 18. So this is significant. This person here is a sad case. I didn't see him initially. I saw him later. 50, when I saw him later, I went back and looked at the chart. 50-year-old man, he's a plumber. He accidentally, he was working on a sink or something in a toilet to unclog something, and he drank by mistake lye, Lye. This is also that's very dangerous. That's very high pH. So here you have a very high pH alkaline substance, which provides the severity. It's not necessarily dilute or not. Bleach, for example, has a pH that's not very high. But yet, you have the issue here because it's lye, very high pH. And of course, this person had esophageal burns. And when I saw him, he came into me with a stricture. So just to show you this example of an accidental case that led to a severe outcome. And I'll show you his X-ray in a little bit. So you saw the range of toxicities here. And, again, what is the chemical that we're talking about? Some of it varies from one to the other. So sodium hypochlorite versus lye, which is potassium hydroxide, it matters. It also matters, if it's concentrated or not. So the concentration matters. And then the chemical properties as well matter. I'll talk to you about that a little bit. And the physical properties too. Also, your physical findings matter. Asymptomatic versus symptomatic. And what are you seeing exactly? Rarely some laboratory abnormalities will help. And then how do you predict the long-term prognosis? So we're going to try to go through this in the next, 20 minutes. The first thing to remember is that acoustic injury is basically an injury to your tissue, histologic damage to the tissue. That's what it's defined as. And typically here, if you're ingesting it, it's going to be in the intestinal tract. If you're inhaling it, the tissue is the lung. If it's your eye, it's the eye tissue. If it's your skin, it's the skin tissue. All of these are caustic injuries, but what brings them together is the damage to the histological damage to the tissue. And the classic basic assessment is based on acid and base. We say this is an acid, this is a base, this is neutral, and then the pH. determines whether it's an acid or a base. And the lower the pH, the stronger the acid. The higher the pH, the stronger the base. And this is really here, if you remember your chemistry, being, a electron donor or not. Okay. And that's the basic mechanism of the tissue damage that you see with these chemicals. I'm sure you guys probably know about this. That's easy. That's simple and straightforward. What's less simple, what's less straightforward is if I tell you that it's not always about a pH. You can have some chemicals with a neutral pH that can cause, excuse me, with neutral pH that cause um, the same histological damage. For example, hydrazine. Hydrazine is in airplane jet fuel, rocket fuel. Hydrazine is an oxidizer. It's not an acid or a base. If you ingest it, it will cause caustic injury by oxidization of the tissue. Hydrofluoric acid and fluorides, that's an acid. It's a weak acid. Its main mechanism of toxicity is through the fluoride, and it causes life-threatening hyperkalemia and hypocalcemia. Although as an acid, it's weak, and it causes severe pain, not because the acid is bad. It causes severe pain because the fluoride binds the bone, the calcium in the bone, and causes the pain. I don't know. This is important to have a lecture on hydrofluoric acid one day. I'm not going to cover it here today unless we have time. Actually warrants its own lecture. White phosphorus. We've seen white phosphorus use in the Middle East, Lebanon, particularly recently. And hydrofluoric acid, white phosphorus is also a unique chemical. It does become phosphoric acid, so it causes an acid burn, but it also ignites upon contact with air and causes a thermal burn. And it can also cause some electrolyte abnormalities because of the phosphorus. So that's a unique chemical called white phosphorus. Nitric acid is listed here. It is an acid, but it causes yellowish discoloration. So it causes yellow skin burns. Remember that for your board exam if you're taking the boards. And last but not least are your chemical weapons, sulfur mustard, lewisite, and phosgene oxime that cause skin blisters, although they don't do it by being an acid or a base. They do it at the cellular level, even at the level of the DNA and RNA synthesis. So they really act at a cellular level to create tissue damage. So I hope you pause here just for 1 second and agree with me that it's not just an acid or a base. There are other things that can cause caustic injury. But let's go back to the common scenarios of alkali and acids. I want to pause here and just recognize that in the US, we don't see often very severe injuries. We still see some death every year in suicidal situations or in industrial situations, but most of our cases are not that severe because of legislations that happens since maybe the 1927 till now. There are several legislations that protected the public that I hope the rest of the world that doesn't have these legislation do that. And I ask you, I challenge you, Dr. Carell and your team, to look into that. These are easy wins. Are there legislations in Nepal to limit the concentration of chemicals in household products? Number one. Number two, the other legislation in the US was the child proof safety caps, closure of the bottles. That's another thing. Do you have that applied? That's another important thing. We've lowered the household concentrations significantly to 3% in some cases. So, like if you are holding in your home chemicals that are 20, 30% concentrated of these acids or bases, that's dangerous. That's the public health intervention that HAPSA can champion, that the Dhulikhel Poision Center can champion to make a simple policy resolution. But these chemicals are useful in the house. You use them to wash your dishes, to open the drains. You use the acids for your toilet bowl cleaner. Of course, we have a lot of acids also in batteries, and people are using batteries for solar power use. Even using hair permanent neutralizers for hair products. And then rust removers of your dish, of your silverware, or your wheels, your wheel caps. All of these are common sources of acids and bases around us. And our customers are either children or adults. And the children, the young children, luckily for us, they're only curious and they can't read. So they typically, get involved in a small amount of ingestion. And this population, it's very important to emphasize another public health measure, which is the safe storage of these chemicals. Unfortunately, people end up storing them in the kitchen, below the kitchen sink, in areas that are accessible to toddlers. The other thing that I've seen is they buy the chemicals from a large, from a shop. The shop usually has a barrel of the acid and pours the chemical in them in another container, often a water bottle. So inappropriate storage of these chemicals often leads to toddler ingestions. In adults, it's a different story. In adults, you have a potential for industrial exposures at work, and you also have the risk here of suicidal exposures, which are large volume. Important to remember from the Advanced Hazmat Lab Support course that alkali cause deeper burns than acids because alkali, by the mechanism of damage to the histological tissue, it is liquefactive. It liquefies as it destroys the tissue, it penetrates deeper and deeper. On the other hand, acids often create a crust. The crust ends up stopping the progression of the exposure and renders the burn relatively more superficial than an alkali burn. They both can have long-term complications, these burns, like cancer, whether it's squamous cell cancer of the esophagus or the stomach. Here's some examples of a sulfuric acid burn. So it's an acid, you expect it to be superficial. You see a little bit the crusting on the mouth and on the chest, just to show you how it causes a crust. It basically coagulates and creates a crust. On the other hand, look at the liquefactive effect of a base, how beefy and juicy this burn is. Some of the risk factors to appreciate are a pH less than 2 or greater than 12. These are bad signs. I said to you physical properties. Yes, if the chemical is a powder or granule, it's worse because it gets stuck in the esophagus and it keeps burning. It doesn't flow and dissipate. A large amount, of course, is bad. Prolonged contact is bad. And if for some reason you have delayed gastric emptying or strictures already in your body, in your intestinal tract, that also makes it worse. Now, remember, occasionally you have some disaster cases. I had a case in Beirut. There was a refugee who was desperate with the situation, suicidal ingestion, presented with an airway compromise. So don't think of all of them as minor or they can wait. Some of these people will come to you with stridor, airway issues, and peritonitis and coma. So be ready for those. Not very common, but they can happen. The more common scenario is, a little bit of mouth pain, throat pain, a little epigastric pain, a little vomiting one time, a little drooling. Those are important. Remember, though, don't exclude severity based on the absence of oral burns because these chemicals sometimes spend very little time in the mouth and they don't necessarily create a burn. So it's not 100% finding. Doesn't really help whether it's there or not. But again, look for physical findings. Look at the eyes if they splash something on their eyes because the eyes need their own care. If you find subcutaneous emphysema, that tells you that there's already a rupture of the esophagus or stomach. So that's important. And then examine, of course, the skin, make sure there are no burns to the skin or any issues with the abdomen exam. The labs are usually not very revealing except for hydrofluoric acid and white phosphorus, for example, and these other chemicals. But for your acid and bases, typically, your classic acid bases, labs are not that revealing, except, like I said, in special cases. A chest x-ray or abdominal x-ray can help look for perforation. Lactic acid can help to look for tissue necrosis. Those can be done if available, but not essential. Now, how do you manage these cases? And is there a way to grade the injuries? And what do you do with children that are curious, toddlers who ingested small amount or maybe nothing at all? And what are the complications and possible therapies? We'll start with the Zargar grading system for esophageal injuries. I don't know if you know this, Dr. Carell, But Dr. Zargar was with Dr. Ashish Balla in PGI Chandigarh. So I thought about inviting Dr. Balla today with us because he sees a whole different spectrum of injuries like this than me. But I realized it was kind of like last minute, and maybe in the future we can have this lecture next year together, me and him, if you want.
And maybe
But
he'll come to Nepal in December.
I hope so. That'd be great. We
Yeah.
should let him know. So the Zargar classification is interesting because it kind of shows you what I showed you earlier, the grade one, and then the grade two and grade three. Okay, look at grade three. Here you have necrosis. Grade two, you have ulcerations, exudates, which we saw earlier, if you remember. And remember that we talked about circumferential or non-circumferential. So non-circumferential is an A, circumferential is a B. Okay, so take a look at that. Grade one, grade two, grade three, 2A, 2B, 3A, 3B. Why does it matter? It matters for the long-term outcome. For example, all grade three burns will develop a stricture. So you can't do anything else about it. They're going to develop a stricture. Grade two, for example, grade 2A may or may not develop a stricture. Grade 2B may or may not develop a stricture, but more likely to develop a stricture. Grade 1 doesn't develop a stricture. Okay, so why is that important? It's important because you want to know what to plan for this patient long term. So that's why you scope them. You scope them because you want to see whether they're grade 1, they're going to be fine, there's no risk of cancer, there's no risk of stricture, or are they grade 2 or grade 3 and then they're going to have a stricture. I'm going to have follow-ups on them. I need to treat the stricture in the future, maybe surgery or dilatation. I got to do something. And also, I got to surveil them for cancer. So that's why you do the endoscopy. Remember, these strictures can happen quickly. Remember, I told you my plumber patient? 2 weeks later, he developed this. Look at the stricture in his esophagus. This is 2 weeks later. I saw him at that point. I saw him because he was having trouble swallowing. And then I asked him, then he told me 2 weeks ago I drank. And believe it or not, this person that this plumber ended up also having electrolyte abnormalities when we put a PEG tube in him, and that he wasn't watching what he was feeding to the PEG tube and developed electrolyte abnormalities. And these are long term, and also they can be complicated with cancer as well, long term. So as you see with these grade two and grade three, there's a long term follow up and complication, and that's why it's important to scope these people. And of course, after you secure the airway and all that, of course, don't do charcoal. Charcoal in this case is bad because one, it obscures your endoscopy view, and it also can cause peritonitis if there's a perforation. The NG tube suction, nasogastric tube suction, if they come in really quickly, you try to suck it out. But I mean, they have to be there in my ED within like 15 minutes of the ingestion for me to do this. Otherwise, I won't do it. And then look for signs and symptoms of toxicity. This is particularly important in children and tested in children. You look at vomiting, drooling, and stridor. If one or zero of these findings are present, then usually there's no esophageal injury. If two or three of these are available, then there needs to be an injury and a scope is necessary. So this is kind of a decision rule that was tested in 79 children only once, that tells you who to triage for endoscopy, who to triage for no endoscopy. But again, it depends on the clinical assessment and your discussion with the consultant. So zero or one finding, you can probably get away without an endoscopy. Two or three findings, endoscopy. In children who are usually, small dose ingested, exploratory ingestion. The endoscopy, to be done safely, it has to be done early because the longer you wait, the tissue becomes friable and the complications become higher of the endoscopy. So you do it early, 12 to 24 hours, and then you don't do it between the 5 days and 2 weeks after the ingestion. And then you do it afterwards to look for strictures and planning for the future management. Okay. This is a grade one burn that I saw in the University of Alabama at Birmingham on endoscopy. Now you hear people talk about steroids and antibiotics. They talk about steroids and antibiotics with the hope that they can they could modify the prognosis of grade 2A injuries. Because remember, grade 2A injury, we said they may or may not develop stricture, so maybe we can modify this outcome. And there are some studies in animals, some in humans, that showed maybe a benefit by giving people steroids for 2 to 3 weeks and antibiotics to make sure they don't get an infection because they're immunocompromised. And hopefully they'll have less grade 2A. And there's like some studies that showed benefit. There's also a variety of steroid protocols for this. But currently, the meta-analyses that are out there and the expert opinion on this is that they don't make a difference. And then remember, grade 3 is going to progress anyway to a stricture. And then grade 2A evidence is limited for steroids and antibiotics. And it's concerning because antibiotics can cause immunocompromised state, and that potentially can have its own complications. The initial idea was that if you give steroids, you decrease inflammation, which leads to stricture formation, but has not been shown in human studies consistently and reliably. Many of these studies, unfortunately, they don't differentiate whether it was grade 2 or grade 3. They lump them together. And those that did differentiate, they didn't really differentiate 2A from 2B. So to be continued. I think this requires a study, maybe in Nepal, maybe in India, where they see enough of these cases. So if you see enough of these cases in Nepal, this could be a study, a prospective study where you would have, you randomize people to steroids and antibiotic versus no steroids. You do a proper endoscopy, you get 2A diagnosis separated, see if it makes a difference for 2A. Now, surgeons get involved in some of these cases when there's a perforation. They get involved when there's a stricture that needs to be, treated by esophageal replacement. But again, they don't necessarily have to get involved immediately unless there's a perforation. But for these strictures, it's more of an outpatient follow-up. Also, remember not to ignore the eyes. Base burn to the eye is deeper than acid, and those can be deleterious and cause corneal opacification, requiring corneal transplant. So these people require urgent irrigation with liters and liters of saline using a Morgan's lens if available, and an urgent ophthalmological consultation to assess the corneal defect and see if there's any corneal perforation. And they will guide the management at that point for these eye injuries. But don't forget about the eye exposures to these chemicals. I think since I have time, maybe we'll cover hydrofluoric acid a little bit, Dr. Carell, and then we can leave some time for questions.
Yeah,
Hydrofluoric,
absolutely.
yeah, let's do that. Hydrofluoric
Yeah.
acid, yes?
No, no, go ahead. I think that's a good idea.
Yeah, hydrofluoric acid is also interesting. Hydrofluoric acid is interesting because it is, like I said, it's a weak acid. I'm gonna stop sharing and pull up some slides just to illustrate some of what I'm talking about. Hydrofluoric acid, the issue there is fluoride. The fluoride anion penetrates deeply. It's a small molecule. It enters deeply into the bone, binds the calcium, causes severe pain, and causes hypocalcemia and hypomagnesemia. A complication of hypocalcemia is hyperkalemia, and hyperkalemia can lead to cardiac arrest in these cases. Hydrofluoric acid is used as a rust remover. We use it when we have silverware we want to clean. We use it to clean the tires of our cars, the tire cap of a car. And typically, the concentration of household products is less than 10%. And those are usually mild exposures. Occasionally, you have industrial exposures to 50, 70% hydrofluoric acid, where people get severe toxicity rapidly and die despite intensive treatment efforts. Where do you see these industrial hydrofluoric acid exposures? You see those in aluminum plants. The first time I went to Oman, the country of Oman, where Dr. Badria is from, Dr. Karel, I had an email from a company, a random email, emailing me from Oman, asking me if I would be willing to travel to Oman to develop training for hydrofluoric acid management. I was like, why? They're like, I was interested. I was like, that's interesting, like an industrial consultation for a toxicologist. That's good. And then the company's name is one of the biggest companies in Oman, actually. It's called Sohar Aluminium. So that's my first encounter with aluminum and hydrofluoric acid. And it's one of the biggest companies in Oman that makes aluminum. Also, the other place you'll see a lot of hydrofluoric acid is in refineries, petroleum industry. That's another place. So that's important. And hydrofluoric acid, in the cases that I've seen, are mild cases. Somebody's cleaning, their tire or silverware, and check this out. They typically don't have any symptoms. Then 6 hours later, 12 hours later, their hands start burning. Then they come to you. That's a good sign because when you have delay in onset of symptoms, it tells me that the concentration was less than 10% and the exposure was limited. Those that have present rapidly typically have a large dose or a large concentration. And those are the ones that get really sick. When they come to you, you look at their fingers, there's a burn, okay? And they're hurting a lot. But the burn is not that, I mean, there's a burn, but it's not like that bad. But they're shouting of pain. That's because the fluoride and the calcium is binding. And this is cutaneous contact. Of course, you have inhalational exposure, those are always dangerous. You have eye exposures, those are dangerous as well. And you also have ingestions, those are dangerous as well. But the most common ones are cutaneous exposures. And the concentration, like I said, is important. We had a person in Atlanta who was in an aluminum factory, and the whole vat container of hydrofluoric acid, 70% fell on him. He immediately removed his clothes and washed himself at the factory because they usually know this is a danger, so they're ready. He came to Grady and he died. Despite intensive efforts, he developed refractory hypocalcemia despite giving him calcium through every single IV and central line. And we couldn't keep up with him. The treatment of these cases, again, is calcium, okay, because they get hypocalcemic. Um, Typically, when you see these cases, you check a calcium level. Now, in the minor cases, like less than 10% cutaneous, you don't see any major issues. But checking the calcium is important. Checking the potassium is important. The magnesium. Getting an EKG to look for any hypocalcemia effects that predispose for torsade de plant or hyperkalemic effects. Checking for those is important. And treatment. Treatment can be cutaneous, topical administration of calcium gluconate gel, which you can make by mixing calcium gluconate with KY jelly. You can also use calcium hydroxide antacid tablets. You can crush them and add them to some jelly and use that as a topical. There are also some commercially available topical calcium gluconate gel. The next level of treatment is, in severe cases, of course, is intravenous calcium gluconate or calcium chloride. Remember, calcium chloride can give you 3 times as much calcium per ampoule compared to calcium gluconate. So it's more calcium for your buck.
Ozzy, are you
So when
sharing
you're
a lecture? Are you sharing a slide right now?
not yet, I'm
Oh,
just
okay, okay.
running my mouth right now
Okay,
after
okay. I didn't know if you're like looking at
no, no,
something and
I'm
we're
not.
not seeing it.
But I'm saying that calcium chloride is much faster calcium administration. The problem with calcium chloride is you need a central line. Because if calcium chloride extravasates, it can cause a burn. On the other hand, calcium gluconate is safer if it extravasates. As a matter of fact, you can administer calcium gluconate intradermally at a local site of burn with hydrofluoric acid to relieve the pain. So that's the treatment for all of this. You can also nebulize calcium gluconate, and you can also use some calcium gluconate topically for eye burns. Although that's not always necessarily efficacious, but you can try that if you have an eye burn with hydrofluoric acid. Um, Finally, remember to sometimes consider that the hydrofluoric acid is under the nail. In that case, you do a digital block, you remove the nail, you wash under the nail with calcium gluconate gel to relieve the pain. There's also finger exposures that are refractory to topical administration. You can do a radial art line and administer calcium gluconate for about 6 hours. That will treat the pain in the fingers. Okay, that's often better than just doing topical if it's not working for you. Um, Let me pull up some slides real quick just to show you what I talked about, and then we can open it up for questions.
And if you guys have questions while he's talking, you can type it here too, and we can get back to him.
Okay, here we go. Share screen.
Kazi, there was a question. Any role of gastric lavage or charcoal in?
No, so charcoal we said no because it's gonna
Yeah.
obscure your image, your vision. And then lavage, certainly not. I mean, this is a liquid. You can do an NG tube suction um, if you want. What is this? I'm sorry. Yeah, this is our case at Grady. So you see the burn is not that impressive, but the pain is severe. The first mistake we made with this case was that we tried this topical and then we discharged him home and he didn't know how to do the topical there. He didn't know how to put it there for hours. He came back in pain. The way we ended up treating this person is by radial artery calcium gluconate with great success. And we avoided having to pull all his nails off, which was nice. Um, what is this here? Yeah, this is, you see how under the nail beds you have the acid here located. Um, this is, you can mix up Tums, calcium hydroxide, antacid with KY jelly to make calcium gluconate gel. There are some prescriptions how to do that. Um, oh, this is the art line to give calcium gluconate. Remember, you cannot do this for calcium chloride. It has to be calcium gluconate, and it helps the pain with the burns. I found this to be quite effective personally. What else I have? This is not important. This is a Poision Center protocol. Look at that. I can't find my lecture, Dr. Correll, the actual slide set. Yeah.
That's okay. I think this probably deserves a separate session anyways.
Yeah.
So
Yeah, that's fine.
um,
We can stop it here
yeah,
and then take some questions for the rest of the time.
yeah.
Anyway, so thanks again for your attention. I'll send some of these slides back to you to look at, and then looking forward to your discussion.
All right. Does anyone, there's some questions here on the chat, but you can also open your video and ask the question directly. Dr. Kazi sounds very scary, but he's very nice.
So they're asking, Dr. Anita Shah is asking about, I think she's asking about phenol, not phenol, phenol. Yes, phenol is an oxidizing agent. It causes actually hypopigmented and anesthetic burns a little bit. And the good news is with phenol, Dr. Shah, is that now we see very low concentrations. In the past, when we had higher concentrations, the burns were more severe. But now they're pretty low, that we don't see any major issues with it. Same with hydrogen peroxide too. Hydrogen peroxide is interesting because we use it now to gargle with for our mouth, and these are low concentrations. But high concentrations of hydrogen peroxide can cause burns, and they can cause also air embolization, which is really interesting. And you can treat that with hyperbaric therapy. Any other questions? They are scared of me.
Yeah. Any other question? And remember, Dr. Kazi will be in Nepal in December 15 and 16, so you'll get to meet him also. There's a question about kerosene and petroleum ingestion.
Yeah, it's appropriate to talk about these, but these are not necessarily acids or bases. And what they do is they cause irritation. They cause irritation, they cause defatting dermatitis, but they don't cause caustic burns. They can cause irritation for sure. And again, the risk here from ingestion is aspiration, pneumonia, as well as from inhalation is narcosis and CNS depression. Plug my computer. My computer is dying. So I hope you found this useful. I mean, remember what we talked about. We talked about acids and bases and the non-acid, non-base caustic injuries. We talked about that. We talked about the physical properties, chemical properties, the pH with bad prognosis. We highlighted the suicidality issue. We also discussed the Zargar classification, the role of endoscopy, the prognosis of these injuries, and the decision rule in children. What about Harpic poisoning? What is Harpic poisoning?
Harpic is like a hydrochloric acid base,
Yeah,
like a
same,
cleaning,
same.
like a toilet cleaning thing.
Yep. So that you treat as an acid, concentration, dose, suicidal, non-suicidal. Any way to prevent esophageal stricture? No. I mean, like, as far as I think today, no. Like I showed you the evidence. There's some studies that showed some benefit. There's a study in Turkey that found benefit in pediatrics, but there are also studies that showed no benefit, and some studies that showed even potentially harm. Most mosquito repellent poisoning in children. What is that? Pyrethroid, maybe? This could be a pyrethroid,
Yeah,
pyrethrins and pyrethroids. Those can
like the
be,
DEET, the DEET
yeah.
product, I guess.
Some of these products can cause CNS effects. So yes, I mean, if it's a significant exposure, it can cause a CNS hyperexcitation, stimulation. I think Dr. Yoon Suk Lee, my fellow who's from Korea, he's on the call. He had a recent case of pyrethrin exposure that we were concerned about. Or he had a DEET. You had a DEET exposure, right, Dr. Yoon? That we were concerned about CNS effects. So yeah, you can have some CNS effects. What is the indication for enteral versus parenteral? That's a good question. So it depends on the severity of the burn. The most important principle here is yes, we need to give them nutrition so they can heal. So that's important. But it depends on the recommendation of the gastroenterologist who does the endoscopy. Do you start 5 days? If it's a minor, if it's a grade 1 burn, you don't need to, you can start feeding immediately. But I guess it becomes tricky with grade 2 and grade 3 when you start oral. And if it's a long time before you can start oral, then you start parenteral feeding. Good question. All right. I'm gonna stop recording from my side at least.
Okay. Yeah, no, thank you so much, Dr. Kazi. I think as we end, we have Dr. Raj also here, who is, our going to be our new fellow with Emory and leading our work at Dhulikhel Hospital. He's a faculty at Dhulikhel Hospital. Raj, I don't know if you have a few words you want to say about our upcoming conference and let people know. Yeah, please go ahead.
Hi, everyone. Hi, Dr. Kazi. Namaskar.
Hello, namaskar.
Yeah, really great to have you for this session. Yeah, it was a great session. Yeah, corrosive ingestion is a very overlooked issue, and we feel very helpless, while managing these kind of patients. In our setup, mostly kerosene and some toilet related, these chemicals are pretty common. I was wondering, one person also was putting a question regarding like, can we use, let's say, weak alkali for strong acid burns
No.
or throw
Yeah.
around?
So yeah, that's a
Yeah,
great question.
right.
People used to talk about this before, as you said. Yeah, don't do that because neutralization can generate heat and cause thermal burns. So we don't neutralize. We don't
Yeah,
dilute with milk or anything like that either. I should have mentioned that. And then what we'll do,
absolutely.
Dr. Dangal, is we will share with you the Georgia Poision Center protocol so that the Dhulikhel Poision Center can start, adapting it to your local context, your local products, but use that as a template. It'll be good to do that because as you said, these exposures can be common in children, and having a way to avoid sending people to the hospital if possible is a good idea, and also having a way to manage these in a uniform manner is a good idea too. So having a protocol, this is kind of one of the high yield protocols for the Poison Center.
Yeah, for sure. Yeah, thank you. And for everybody, as Dr. Ram already mentioned, so we are planning for a international, at least for now, conference during December mid. So we'll be disseminating further information through our social media handle or from some emails also for those who have been registered in our these webinars, I think. Uh, and thank you everybody for joining this session. I think that's it from my side, Ram. Thank you. Yeah, and thank you, Dr. Kazi, for joining, and thank you, everybody.
Nice to see you, Raj, and we'll follow up with you and I by WhatsApp.
Sure.
Yeah.
Thanks.
Thank you so much. And please don't forget to do this feedback form. That really helps us improve next sessions. And yeah, really thank you again to Dr. Kazi, who is fantastic as always. Your lecture was really insightful and hopefully really helpful. And this recording will be available for all your friends to watch as well. So we'll send you the recording on your email. Stay connected with us for our next month's webinar. And also remember, we do this emergency care teaching series also. That's a separate to the poisoning webinar. So that happens every other month. So please, again, like I said, go to our Instagram and you'll know all about this. So um, uh, thank you so much. If you don't have any more questions, we'll end our meeting here for today. Bye-bye. Bye,
Dr.
everyone.
Dangle, can you stay with me a little bit?
Yes, I'll stay with you.
And Dr. Dangle, too.